we're seeing if we could get the translated slides up on our, and it works. Yes. Excellent. So I worked on that before this talk, so hopefully it will make it easier for you to understand, because I've talked about rotational atherectomy in the past, and I've talked about different tricks, and hopefully today I will show you something a little bit novel for you to think about. When we talk about atherectomy, we really talk about rotational atherectomy or rotablator. This technology has been around for over 20 years with almost 1 million procedures done. And so even though there are different technologies that talk about, fall into the class of atherectomy for interventional classifications or reimbursement, rotablator is atherectomy in my mind, and I'm going to talk a little bit about some tricks. Even though it's been around for 20 years, there's a next generation coming soon, but in reality, the principles are the same, and it's just really to help the staff feel a little bit more comfortable with using the device. What's happened, though, over the last 20 years is that there's much more complex lesions that are being done today, and we still have episodes of roto-regret. This is a patient that I treated post-myocardial infarction. I thought she was young, in their early 50s, and I did not appreciate the calcium, and this is what it looked like after a stent. Typical roto-regret with non-compliant, high-pressure dilatations. This would not open up, and I ultimately had to use rotablator to draw out the stent. I still do that occasionally, but I believe that we have better technologies, and I'll talk about that at the end of this talk. But roto-regret continues to happen, and in the United States, we're at a phase where we're using rotablator perhaps more readily, and the reason is that with rotablator, as the operators know in this room, you can get hemodynamic changes, hypotension, sometimes some slow flow, no flow, things that you have to take care of. I call them the challenges, not complications, because it happens as part of the routine. But we have left ventricular support devices. Most recently, Impella has been used very often associated with rotablator procedures. The problem is that this device costs $25,000 US, and the people in China says, well, you know, you do a lot of rotablator in the US because you have Impella. Well, I will tell you that the balloon pump is just as helpful if you know how to use it. And in my experience of thousands of rotablator, I've only used Impella once. And I think we had a talk earlier this morning on CTOs and left ventricular dysfunction and multivessel disease. Chip type cases, I do believe there is a role for Impella, but for routine rotablator, good technique, use suppressors, and a balloon pump are, and a good team in the cath lab is really all you need. What really has driven the growth of rotablator in the United States is the fact that now, despite the fact that we are dealing with older patients, patients with diabetes and renal failure, realistically, we are now taking care of patients who used to go to surgery for their valve. And now they're having their valve disease treated with percutaneous technique, TAVR, and as a result, we are taking care of their calcified coronary artery disease. And this leads to increased growth of rotablator in the United States. And you can see that worldwide, this is actually happening as well as in China, and you see the growth here, but the penetration in China is still very low, 0.8% compared to 4% in the United States, and Japan leading the world at almost 6%. In my practice, as we talked about more complex disease, even though I do a lot of CTOs, and in the past we were told that we treated a lot of left main coronary disease because of failed bypass surgeries. In reality, the biggest growth in my practice has been unprotected left main coronaries. And I want to talk a little bit about the different tricks that you can use for using rotational atherectomy. Now, we know that rotational atherectomy is helpful in highly calcified, unprotected left main coronary arteries. In this series, you can see that actually it does not show up very well, but the mother vessel had only 2.4% target lesion revascularization after 1 year, but this did not hold up in patients who were on dialysis. So no question that renal patients are different. But what this study showed is that rotational atherectomy as an adjunct to our treatment was very helpful in giving us better long-term results. The question then becomes, how else can you optimize your treatment of left main coronary disease? These are larger vessels. The lesions are often eccentric. There's superficial calcium, there's deep calcium. How do you take care of that? And we all know that when you use 2 stents for taking care of distal left main bifurcation disease, ultimately there's a higher in-stent restenosis rate, usually in the circumflex. So how might we treat these lesions better with rotational atherectomy? In the past, when we took care of large vessels, osteal lesions, like this osteal LAD restenosis, we would use large burrs, and in this age of plaque modification, we actually, instead of using larger burrs, have developed the approach of using a hybrid approach using cutting balloon to treating these large vessels. And as you can see, you can come up with a very nice result. Just a reminder for those of you in the audience that don't know too much about the cutting balloon. The cutting balloon is a high pressure balloon that has blades mounted on. They're athertomes. They're very, very sharp, and they cause micro cuts into the intima. I like to use, usually if I can in a large vessel, a 3.5 balloon because it has 4 blades instead of 3 blades. So even if the vessel is a little bit on the smaller side, I like to use the larger balloon, 3.5, at a lower pressure to get that extra cut or a little bit extra effect from the cutting balloon. For osteal lesions, historically, we were taught for rotablator to use the largest burr possible. So, you know, it was sometimes a 2.25 or 2.5 millimeter burr, but this required that we use 9 to 10 French guides. The concept was core out the osteal lesion, which was really a reflection of disease in the aortic wall. People like to use cutting balloons, as I've showed you, but because of that small cut, if you inject into that cut inadvertently, you can cause a hydraulic dissection of the aortic wall. So this is a typical right coronary osteal lesion, and I came up with this technique of, instead of using large burrs, we use smaller burrs, and we use a smaller burr that and a non-supportive guide, so that we would pull the guide up and do atherectomy from above and do atherectomy from below to get the effect of the circumferential osteal lesion without using the big burr and also the associated big guide that you needed. And this is the kind of results that you could get. So I've used that technique for many, many years for osteal right lesions. And then I started thinking about how can you use this for left main coronary lesions. And it turns out that many of the lesions in the left main are eccentric. So by the use of a guide and wire, you could actually bias the burr against the lesions. In the United States, we have extra support wires, which are a bit more supportive, but I know that you do not have those in China here. The best guide isn't necessarily one kind of guide, but whatever seats best into lesion based on the anatomy and orientation of the left main coronary artery. And as opposed to the techniques of pecking and trying not to spend too much time on the lesion for heat generation, we actually sometimes use the burr now and keep it in place so that it digs deeper and deeper into the eccentric plaque, sometimes not to ablate the plaque completely, but to get deep into the vessel and take care and have some effect on the deep calcium. So the ideal atherectomy results in a double barrel type channel and angiogram, and I'll show you what I mean by that. So, as I mentioned, many lesions in the left main are eccentric. This, you can see that is, here is the LAD, here's the circumflex. Just the wiring of the lesions. Everybody has their favorite wire. We usually exchange them for the rotor wire, and you can see how the plaque is very eccentric, and the burr is cutting across the inferior aspect of the plaque. As opposed to a pecking technique, if you keep the burr in this one spot, then the burr can dig deeper and deeper into that plaque. As you see on this angiogram, you actually have a double barrel. You can see that the balloon and the stent is setting deep into the original plaque right here. And this is the kind of result that you can get. So I took that concept and started seeing more eccentric lesions as here. It's very similar to the one I just showed you, but I wanted to kind of show you something else you can do here. So we have an eccentric lesion. We actually decided to burr into the circumflex because I could not get the wiring. But usually, if you have a complex lesion, you usually do, I usually rotablate into the circumflex because getting into LAD is easier than into the circumflex. After atherectomy, you can see that the channel is a little bit better into the LAD. We're able to facilitate and do rotablation into the LAD, and again, a little bit more prolonged placement of the burr in the LAD or the lesion. And on this one, you say, what am I showing you here? Well, what you're going to see is with this is actually you see the guide coming down. It doesn't show very well, but I talked about using the wire and the guide to bias the burr into the lesion. So with the long wires, it's very easy to exchange for a different type of guide. Again, you see the orientation on this. Here's my original guide, and here's the lesion right here. So the guide is sitting quite back, and the burr going into the LAD is going on the underside of the lesion and can only bite into the lesion if the wire is very strong and has a strong bias. But by exchanging for a guide that sits deeper into the artery and coaxial, you can see that the tip of the guide is right against the lesion. And now when the burr comes out of the guide, it goes right into the lesion, and it actually gives me better directional atherectomy. And you can see even here, I actually advanced the guide so that the burr is sitting right into the lesion so that I can impact that. So sometimes what this shows is that using a smaller burr is better than using a bigger burr, because a bigger burr would have a harder time digging deep into the plaque and having some impact on the deep calcium. And then the result that you have would be here, where again you see not as evident as the next slide will show you, where the wire now is setting deeper into the plaque, or giving me the double barrel appearance. And here's my final angiogram. Okay. Those were LAD lesions. This is a circumflex lesion here. And again, what this best shows, and you can see this, is you can see where the original lumen took a 90-degree turn off the left main, and I thought hopefully you can appreciate from the back where there's a double channel, and from the deep cutting from the rotablation using a small burr. And that was, we get a good result from that. So I just wanted to introduce that concept of actually really focused, deep treatment using a small burr. I'm going to just go through quickly. CSI is a different type of atherectomy, and it's supposed to treat it's like rotoblator, but it doesn't, because you can see that over time, because it's eccentric, it moves up and down through the vessel, so it does not allow you to focus the treatment on the lesion as we talked about. And finally, I wanted to just mention that with in-stent restenosis or suboptimally displaced stents, rotoregret, laser has been shown to be very helpful with the injection of contrast. And what happens is that the contrast absorbs the energy and causes an acoustic mechanical effect on the deep tissue, and allows you to treat in-stent restenosis as well. And I just want to show this final angiogram where oftentimes it absorbs so much energy and it has such an impact on the tissue, there's a generation of gas. I actually don't think you can see it very well. So, but just to be assured that the use of contrast will actually augment the effect of laser. You oftentimes get gas. Do not be afraid about it, because it will make your effect of laser more important. So finally, I thank you very much for your attention.